everyone, welcome back to my channel, and if you are new here, I am Mariana and I interview the brightest minds of physical therapy. If you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today, our guest is Dr. Mark Laslett, and he's going to talk about his 50 years of experience as a physical therapist and his journey so far, diagnosis and classification of lumbopelvic spine, treatment and management of acute and chronic pain, and the courses he teaches. Mark graduated in 1971 and completed his diploma in manipulative therapy in 1976 and the diploma in mechanical diagnosis and therapy in 1991. He has over 40 publications and published his own text, Mechanical Diagnosis and Therapy, the Upper Limb, in 1996. I hope you enjoyed the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer. Systems for PT, the Do Anything Anytime EMR. Systems for PT develops systems for clinicians so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Hi Mark, welcome to PT Pro Talk. How are you today?
Very well, thank you. Nice to meet you.
It's a pleasure to meet you. I'm super excited to our conversation. Looking forward to learn a lot with you with your 50 years of experience. So let's jump right in. Could you tell us a little bit about yourself, your career, and how did you get to where you are right now?
I graduated from physiotherapy school, and at that time there was only one physiotherapy school in New Zealand, and in 1971. And 5 months later, I took over a private practice in Auckland, New Zealand. And I think at the age of 21, I think I'm still the youngest person ever to go into private practice on his own account. So that was in 1971. So that's like really 50 years ago. And and 6 months later, I bought the practice. So that was in 1972. So I actually owned the practice. I only leased it to start with for 6 months because the person had to go on holiday, and it's not on holiday, he had to go and have an operation and get a total hip replacement and stuff like that. So I took over his practice for 6 months and then I bought it. And so that happened there. And I guess in terms of the interest of the group, the listeners, my part of the things that was special, I guess, about my background is that I had the enormously great fortune to spend in my last year of physiotherapy school in 1970. We were on rotation at Auckland Hospital, and we were going from department to department, just like all physiotherapy students do. And one of my rotations was with Dr. Ian Broadfoot. And he was, at that time, there was no medical specialty of musculoskeletal medicine or sports medicine. It was just you didn't even have rehabilitation specialists. You had rheumatology and orthopedic surgery. That was it. So the physical medicine specialists were only regular GPs who had taken a special interest in it and had specialized on their own account, but they were not registered as specialists. But the hospital system recognized them as having special interest or special skills. And Dr. Ian Broadfoot was one of those, and he practiced part-time at the Auckland Hospital, and I had 6 weeks standing in a corner watching him do essentially a sacroiliac assessment of the extremities and treatments and injections and all that sort of stuff, and manipulative therapy based upon a French system by Robert Maine from Paris, because Dr. Ian Broadfoot had spent time traveling the world, as Kiwis often do, and he spent time with sacroiliacs in London and with Robert Maine in Paris. And he came back, and that's what he used to do. And so I learned to manipulate just by watching Ian Broadfoot when I was still a student. And the next rotation I went to was, it's awesome, isn't it?
Yes, awesome.
I mean, I was 20 years of age. I mean, what did I know? You know, I mean,
yeah.
But what did I didn't know enough to be scared. And of course, a 20-year-old male is bulletproof anyway, as you know. So anyway, so my next rotation was at the National Women's Hospital, where we're doing the obstetrics round. And my supervisor was I even remember her name was Moana Cameron. She was a physiotherapist, a lovely lady. And one day during that rotation, she came in with neck pain. And she was, I've got a sore neck today. And I said, I've just spent 6 weeks watching Dr. Broadfoot. And she said, what would he do? And I'd say, well, you do this, and you do that, and you do this. And then what would he do? She said, he'd manipulate your neck because there was a certain pattern and blah, blah. He says, she asked me, can you do that? I said, sure.
Yes.
And so she lay down, and I examined her, and she said, there's a particular pattern. This is what you're supposed to do according to the right main system. And I manipulated it, and it went off like a bunch of firecrackers. And she got up, she said, that's fantastic. So, I mean, from that time, you can imagine me having only had a tiny little bit of exposure to Jeff Maitland stuff before seeing Ian Broadfoot. Then 6 weeks of just standing in the corner watching. We talked a lot, but I didn't do anything. That was the first time I ever did anything to anybody. And so I started manipulating before I was even qualified. The first manipulation I ever did was on the neck. Oh my God. And that's scary in today's standard, but it wasn't scary back then. And then of course I went into private practice almost maybe a year later, and that's what I did. I just did what Ian Broadfoot did. And so even before I had any formal training and people testing me and observing me, I was doing that stuff to patients long before I had any training. And that was like an amazingly brilliant experience that's almost unique, I suppose, in many ways. I mean, many other people watched these people as well, but for some reason it just resonated with me, and I became fascinated by making a clinical diagnosis, pathoanatomic diagnosis, manual therapy, manipulative therapy, and that sort of thing. And then about 2 years later, I met Robin McKenzie, and he was most people don't realize that Robin McKenzie and Brian Mulligan both were two of the key starters of manipulative therapy in New Zealand. And they did that about the time I qualified, about 1971 or 69 or 70 or something like that. And they formed the New Zealand Manipulative Therapist Association in order to teach physiotherapists how to mobilize and manipulate and do diagnostics. And my first teacher, so I started that diploma course in 1974, and Brian Mulligan taught the extremity section of the course, and they were teaching not their own material. They were teaching the material by Freddie Kaltenborn and Olaf Evjen from Norway, and they were teaching that Nordic system. So they taught. Brian Mulligan taught the Nordic system for the extremities, and McKenzie taught the Nordic system for the neck, for the spine. And this is before McKenzie ever wrote anything down, really, of his own material. And so in 1976, I got my diploma in manipulative therapy. I think I'm number 21 on the register. So the first 10, McKenzie's 1, Brian Mulligan's 2, and then there's another 8. Another 8 got there. They basically examined each other and gave themselves a diploma. I mean, it's and then the next 11. I'm the 11th after that. So I mean, it's just bizarre, but it's just the way. That's
crazy.
Well, what Mulligan and McKenzie and about 10 other people did was that they went to the physiotherapy school at the time and said, we need to start teaching physiotherapists how to do these things. And they said no. So they said, oh, we'll do it ourselves. That's what New Zealanders do. If you can't get the people who are supposed to do it, you just do it yourself. And so that's what they did. And when I was during that time, during the mid-70s, when I was actually still a student, we had a group of people up at Auckland who were going through the course at the same time, and we used to get together. And I found myself more often than not being the teacher. And so once I qualified and had my diploma, I started assisting Mackenzie and Brian Mulligan on the courses. And then very quickly, Mackenzie stopped teaching that, started teaching his own material. So I became a teacher on the NZRPS courses. And then I started teaching for Mackenzie, and I did that for 15 years. And that was only the spinal stuff. I never did any of Mackenzie's extremity stuff because I have a different opinion about the extremities. So in fact, I was already teaching the extremity joints diagnosis and treatment through the 1980s and 90s. And it was me who tried to get the Mackenzie Institute to start an extremity joint program, and I offered them my material, and they didn't want it. So I went off. I continued to do my own stuff, and I published a book in 1996 on the mechanical diagnosis and therapy for the upper limb, which is now sold out, and I'm not going to do a second edition. And then I did a PhD. I sold my house. I sold my practices, and moved into an apartment that my wife and I owned. This is in 2001. And then I did a PhD out of Sweden on diagnostics, and working with Dr. Aprill in New Orleans, who's now retired. And that's when I started publishing in the 80s, but really the serious stuff didn't start until I really did my PhD. But and all through that time, of course, I was running practices and seeing. In those days, during the first 7 years of my practice, I was seeing maybe between 40 and 45 patients a day.
Oh, wow. That's a lot of patients.
Well, we did. We saw lots and lots of people. And then the practice got so big that I couldn't cope anymore. I was working 12 hours straight without a break. And I thought, you can't go on like this. And I'd get home after my kids were in bed, and things like that were not a good thing. So what we did was we bought a piece of land. We built our own clinic, actually constructed our own physiotherapy clinic, and I started employing people, and we had 3 physiotherapists, myself and 2 others, and I think the busiest we ever got, we saw 104 people in one day.
Oh, wow.
So that was really big, and we were seeing like 10 new patients every day, of whom at least 5 of those would be lumbar spines.
Oh, wow.
So we had a large medical practice just not far from my clinic that used to treat me as an immediate orthopedic opinion. And so whenever a person with a musculoskeletal condition came into their office, they would just say, "I'll just go up the road, just go away." And so I saw people walking in to just sprain their ankle. People were literally turning up on my doorstep who just only 5 minutes ago put their back out. That was my practice for 25 years. And so we were like an immediate, almost an emergency clinic. And as time went on, I started to see more and more difficult patients who had, you get a sort of a bit of a reputation. And so even though the bulk of my practice was coming from maybe 20 GPs, about 50% of my caseload came from over 200 GPs all over Auckland. So they would see me 1 or 2 patients a year, but they were always people who had already had lots of physiotherapy and chiropractic and osteopathic and been to see a surgeon and had an MRI or a CT scan or an X-ray and blood tests, and nobody knows what the hell's going on, and I'll go and see him, And so I by the mid 1980s, I'd reached a point where I felt that I could manage successfully and understand 80% of the patients that I saw without any problem at all. I knew what was going on. I knew what was wrong with them. I knew what to do. Then there was the 20% of people for whom I didn't have answers. And, I was a skilled diagnostician by then, and I was a skilled manual therapist, and I was skilled in McKenzie and Mulligan stuff and Carlton-Levy stuff, and we've been reading all that stuff by Melzack and Wall and the gait theory and pain and and Vladimir Yanda stuff and Florence Kendall and Shirley Salmon, and we'd done all of that stuff. We did everything. Acupuncture. I was an acupuncturist for 15 years. We did everything, and so it was just one of those. I reached a point where I thought, there's 20% of people we don't understand. 80%, it's a piece of cake. We know what to do. Person comes in with a shift, we know how to fix that. We know what the problem is, we know what to do. Person comes in with, with a shoulder problem, we know how to identify cuff versus glenohumeral joint versus AC joint versus sternoclavicular versus neck. We know how to do all that. That's easy stuff. But there's 20% of people, and one of them was the sacroiliac joint. Wow. I did a 5-day course with Freddie Carlton-Born in 1976, and he spent 2 days on the sacroiliac joint. And it was all about the sacral position and the relationship to the ilium. And they didn't talk in terms of upslips and downslips and anterior anonymous. That was not the language, but it was the same sort of stuff. And it was all by palpation. And I did that for years. And it's useless. It doesn't work. It doesn't work. Everybody, I don't think I ever fixed anybody by doing that stuff. So I fell back on the Cyriac's pain provocation tests. But of course, we didn't even know if they were reliable or valid or anything like that. We knew from Potter and Rothstein's work in 1981 that the only reliable tests were actually the pain provocation tests, which made a lot of sense to me, because I knew that when Freddie did this with the, seeing what the position of the sacral versus the ilium, and I would go up and I'd go, I'd find something different. And I always assumed that Freddie knew what it was, and he was right, and I was wrong because I was the student, right? Well, then I found when I was doing it, and I thought that I was pretty clever, my students were getting different answers from me. Now, they assumed that I'm the guru and they're the dummies, but it's not true. The truth actually is that these things are unreliable.
Yeah.
Now, we actually know that's true, but we didn't know that back then. We know that's true now. We don't know it's true then. So the point is, if you can't agree, if experts can't agree on whether it's an up or down or forward or sacrum is this way or that way, if we can't agree on that, what's the basis of your diagnosis and treatment? It doesn't mean anything. It's rubbish. So then fortunately, my partner was married to a New Zealand girl. He was German, but he was married to a New Zealander whose uncle was Maynard Williams, who taught statistics at Auckland University of Technology. And so we started having wine and beers together. And he says, well, you have to test for reliability. And I'm going, how do you do that? Because I'm not a mathematics person at all. And he goes, well, it's easy. You do this and that. And I said, well, do it. So we did it. And we published the results in Spine in 94. And suddenly I become the sacroiliac joint guru. What? I didn't know how to treat sacroiliac joints. I thought I knew how to diagnose them. But once I diagnosed them, I didn't know what to do with them.
That's a start, right?
Well, yeah, you have to know you've got one first before you can even just start to begin to know what you should do or shouldn't do. So, and that was fine, and I became sort of semi-famous for that. And then in 1995 at a McKenzie conference in Cambridge in England. I'm presenting my reliability study data to the conference on the sacroiliac joint, and Dr. Charles Aprill, who is a radiologist from New Orleans, was presenting his work that he'd been doing, some of the work that he'd been doing with Robert Metcalf on injecting discography, comparing it to McKenzie's repeated movements assessment for centralization. He was presenting some of that early material, early data. And at the end of my presentation, Charles Aprill comes up to me and he says, "Mark, I'd like you to show me this sacroiliac joint test." I said, "Sure." So we go up to his room and I show him the test, and he says, "That's very interesting. That's good. I'll see what they're like in the clinic." And he says, "Oh, by the way, I've got the shoulder problem. I understand you're writing a book on the shoulder." I said, "Well, he's on the upper limb." So I looked at his shoulder and he had a rotator cuff problem, and I did some friction massage to it and it made it a lot better, and he was very happy. And then at the end of the conference, where Charles Aprill and I were asked by the McKenzie people to present at the next conference, which was in San Diego in 1996. And we would spend a whole half day talking about the sacroiliac joint. So I said to Charles, "Well, look, if that's the case, we're going to do that. Maybe I should, when I pass through the United States, because I'm doing a circuit every year, I should come to your clinic and we should see some patients together and see if I can get it right. See if my clinical decision that's a sacroiliac joint matches your diagnostic injection." And he says, "Absolutely no problem at all." So that's fine. So we agreed that in September of 96, I would go down there and we'd see patients together, and then we'd go off to San Diego to the conference and talk about stuff to McKenzie people. So that was fine. And so in June of 1996, Dr. Paul Dreyfus from Texas, he's now in Washington, but he was in Texas at the time, had just published a paper in Spine comparing sacroiliac joint tests, including allegedly my provocation tests, with diagnostic injection, the very thing that we ultimately went on to do with Dr. Aprill. And he demonstrated that my test, as well as the palpation test, did not predict the injection. In other words, my tests were useless. So I turn up in New Orleans with Dr. Aprill, and I said, "I don't even know why I'm here, Charles, because my tests are useless." And he says, "They're not useless. I've been using them ever since you showed me last year, and I think they're rather good." I said, "Well, Paul has just published this paper." And he said, "Oh, and I've seen that, and I don't agree with it." And I say, "Well, do you know Paul?" He said, "Oh, sure. Yeah, we both teach on the International Society for Injection Specialists," or whatever it is, some organization. Yeah, so I said, "Can I call him?" And he says, "Sure." Gives me the phone. I dial on the number and I speak to him on the phone. And I said, "Paul, can I come up and look at what you guys are doing? See how you're doing my tests? Because I've just seen 10 patients with Dr. Aprill doing the sacroiliac joint test, and I've got everyone right. I mean, I predicted the result, negative or positive injection. Everyone without fail, I've got right. And you're saying that my tests are useless, and somehow there's a disconnect here." He says, "No problem at all." So I jump on an airplane that very afternoon, fly to Dallas, drive 2.5 hours to Tyler, Texas, and I observe Mark Michelson, who's the chiropractor he did the work with, and Paul in the afternoon. So in the morning, the chiropractor, in the afternoon, Paul Dreyfus. And their tests were nothing like my tests, nothing like them.
Aww.
They called them the same names. And so that paper that was published in 96 says my tests are useless, and they're not my tests.
I'm so glad you went there to check.
So, and by the way, that's not in the literature. Nobody's publishing to say, were they really the tests or not the tests? I mean, you don't publish that sort of stuff, do you? So anyway, when Dr. Aprill and I go to San Diego, all right, we present our papers and we're having dinner and drinking wine. And all during this time, there's a female like a satellite around us, all right? and she's from Alabama. And Paul and Charles and I say, look, it's time we did our own study. If Paul Dreyfus' study is no good, we have to do our own. And I said, the problem is that I only come to the United States once a year, and I can't spend a lot of time just waiting for sacroiliac joints to turn up. So, and she says, I'll do it. So that's how that relationship started. And she did most of the patients. I examined 30% of the patients. She examined the other 60%. And it took us 5 years. We finished collecting data in 98. And we had Nick Bogduck look at all our data first before we published it. And he said, it's good, go for it. And it took us 5 years to get it published.
Oh, wow. It's a long time.
That's why it was published in 2003. So we actually had that data for 5 years. But Spine Journal did 3 reviews and then finally rejected it. The Annals of Physical Medicine and Rehabilitation kept our paper for over 8 months and then said, oh, it's no good. And so in the end, we went locally to the Australian Journal of Physiotherapist, that journal, which is now, I think, the Physiotherapy, it's got a different name now, and they published it. So it took 5 years. Oh, that's right. No, Physical Therapy did 3 reviews on it as well, and they kept on wanting. They didn't like it. They said, oh, our statistics are wrong and all the rest of it, and we knew they were right.
Mm-hmm.
They beat us to death for about 18 months.
Why?
Physical therapy. You asking me? I don't know. Why would I know? I mean, we had Bogduck tell us how to write the paper, for God's sake. There's nothing wrong with the paper. They just didn't want to publish it.
Oh, that's sad.
Do you know why they didn't want to publish it, in my opinion?
Yes.
Because it proved you're able to diagnose sacroiliac joint pain. And the spine surgery community didn't want that, and the physical therapy community didn't want to give up their palpation diagnosis. That's why.
I believe that. It could very much be. Well, that's quite a story. Yeah. Yeah.
That's up to 20 years ago.
Let's finish the last 20 years.
50 years. You can't cover 50 years in an hour.
Oh, I think it's just awesome that you had this experience with Mackenzie and Mulligan. I'm so jealous. It's crazy that you had this opportunity.
No, we did actually know those of us who were students of these guys. Those of us did actually know what we had. It's a rare. It's like an alignment of stars almost. It's just like it's a pretty rare thing.
Yeah, that's awesome.
And also in New Zealand, one of the things that we have, which a lot of places in the world don't have, is we have, even though we have a socialized system, we have a dual system where we have a private and public system side by side. And we were able to do anything. We weren't legally limited. So in other words, I've been doing injections since I think the first injection I did was 1981. So I don't do spinal injections, I only do extremity joint ones. But there was nobody to say we weren't allowed to do that. So long as the doctor prescribed the medicine, so long as the doctor was happy for us to do the injection, and I always made sure I did them within a medical centre with the doctor. There was no more dangerous than the doctor doing it. In fact, it's less dangerous because I knew what I was doing and they didn't. So why there was no legal reason for me not to do these things so long as the medical reasons were underway. So we were able to introduce things like manipulation and acupuncture and doing injections, and the radiologists over here didn't worry if they got a referral for an X-ray from a physiotherapist. It doesn't bother them. So we had a clinical freedom that was almost unique back in the 70s, in the 60s and 70s. So people like McKee and Mulligan were able to experiment and to play around and to try different things and that sort of stuff. So they did.
That's awesome. Very different from now.
Well, it's very different still from but a lot of places in Europe, for example, like Germany and Spain, and the French just do what they do anyway. But but even there, there is a lot of the power structure is so intensely medical that that physiotherapists struggle, whereas we have that same power structure, but socially we don't have the same sort of control problem.
Yeah. And
not as much. We had a freedom that other people didn't have.
So we were briefly talking about that before, about the difference on the PT roles in New Zealand comparing to the rest of the world. And I don't know if you want to briefly just mention like the titles, what exactly means, and the difference that what can you do and not do.
You mean the specialty thing?
Yeah.
Yeah. Again, New Zealand's a little different from a lot of other places, and perhaps a role model for others from the legal perspective too, is that in 2013, the New Zealand Physiotherapy Board, which is a board constituted by the New Zealand government, and there's a board for medical doctors, for physiotherapists, for chiropractors, for osteopaths. So there's for all of the medical practitioners out there, there's a board for each one, and they control the legislation, the licensing of physiotherapists and doctors and other people. And they decided, after many, many years of discussion and pressure and lobbying and things, that they would institute a license. They would license physiotherapy specialists. I understand that this is a first in the world. I think that I think the Americans were the first to do to recognize their own specialists, but that was the Physiotherapist Association recognizing their own specialists. And the same, you have the same in Canada, and then you have the same in many places in the world. Australia does it too. And they recognized, they called these people specialists, all right, very early, and we didn't. But our legal system was the first to recognize physiotherapy specialists at the same level as like medical specialists. And so that happened in 2013. I was the first person to go through the process and to become a licensed registered physiotherapy specialist, musculoskeletal, and Dr. Angela Cadogan was the second. And we now have 10 in New Zealand. I mean, it's a small country. 10 is nothing, but we now have 10. And the Accident Compensation Corporation, which is our big insurance company for insuring people against accidents, what have you, a very powerful organization in our system. They now recognize physiotherapy specialists and pay us similar to what a sports medicine specialist would get paid. So we not only are registered licensed specialists, we are also paid as specialists, which is, I don't think happens anywhere else in the world. So I could be wrong in that, but that's my belief. The Aussies are very jealous, and so are the Americans, and all that sort of thing. So it's a little different, yeah.
Yeah. So, that's awesome. It's awesome that you're paid as a specialist too. So yeah, I think everybody's jealous.
When you see patients, the only patients I see are patients who have really big problems. I mean, as you heard, my clinics up until 2001, where I sold my clinics, they were acute clinics, acute and chronic. I mean, that's people walking in off the street. I mean, after just broken their arm or sprain their ankle or hurt their back or put their neck out or something. That was like the bulk of my practice. Well, but I now don't see hardly any of those. It's all chronic and difficult cases that I see now. And I actually video every case and I think maybe last year, I think only 2 people said that I would. They didn't want me to video. So I use that as my, when there's a 1-hour consultation and there's a video going and the whole thing's being videoed. And that's not on the net. That's on my own private secure system. But that's my clinical notes. So I can actually, when I'm doing my notes, I've got a video playing on one screen, and I'm writing my report on another screen. So I've got videos of hundreds of patients.
So I imagine how many different types of patients and cases you saw, and how you develop your diagnose abilities. So that's what I want to talk about next. So could you tell us how do you diagnose special? I know that the area you really like lumbopelvic spine.
That's mostly what I see now. I see necks as well, but I don't see a lot of extremity joint problems, except as they're presenting as back pain, which are not. But no, you have to be very clear on what diagnosis means. Diagnosis simply means diagnosing the source and cause of symptoms. And so source and cause are two different things. Source is the anatomy, which structure is producing the nociception of which pain is created by the brain, from which pain is created by the brain. All right, so that's the anatomical origin of the nociceptive input. The cause is the pathology. Why does that tissue produce nociception? What's the cause? Is it inflammatory? Is it mechanical? What's the reason why it is sore, painful, or nociceptive? Then you have to add to that the influences of the pain experience. Now, the pain experience is not the tissue. The pain experience is what the brain creates from its input. And so you have, first of all, you have a neurophysiological modulating process that happens at the spinal cord and the hindbrain level. And this has got nothing to do with your cognition or your emotion. It's simply the lower vertebral animals all have it too. I mean, we've evolved to be able to modulate our pain experience or our nociceptive experience, because that's a survival trait. If you can switch off pain when you're being chased by a predator, that's a really good thing. If you can increase the pain so that you protect an injured part, that's a good thing. So you can inhibit, so you don't further damage it by whatever. So the ability to modulate that nociceptive input is a survival development. It's just part of our evolution. And but we have evolved beyond just that simplistic neurophysiological modulation to the point where our emotions, our psychological states can down-regulate part of that process as well. So to me, the so-called biopsychosocial model doesn't capture the complexity at all. To me, you have the bio, which has got two parts, source and cause, all right? And you've got the neurophysiological, which is your neuromodulation. And then you've got your psychosocial, and everybody knows that there's at least 11 dimensions in that. So it's a much more complex than a biopsychosocial model. That's a simplistic condensation of a much more complex thing. So when I say diagnosis, I mean, first of all, I want to know source and cause, if I can. I can't always do that, of course. All right, then I want to know what the influences are. Is there sensitization or inhibition of the pain experience or the nociceptive input? What are the psychosocial factors that are influencing how the patient behaves and experiences their nociception? All right. And so that's all, to me, at one level, your pathoanatomy, all right, is your simple diagnostics, all right? Then you have diagnostics in the broad sense, which is all of that. So people call me a reductionist, and I know what that means, and it's bullshit. I'm not a reductionist. I use reductive methods at times, that is true, but I'm not a reductionist in terms of philosophical bent. So here we go. So to me, the first thing is to try and identify the tissue origin of pain. Then next thing, try and find out why that is nociceptively active. And then as part of that process, I learn what is modulating that experience. And sometimes you can't know what the pathoanatomy is because there's so much other stuff going on. That's relatively uncommon. If you're in primary care, most of what you are dealing with is the nociceptive input, and that the psychosocial, neurophysiological stuff, that will resolve itself when the pain resolves. Most of the time, not all. Some people are naturally predisposed to go crazy. All right, and certain cultures have weird attitudes to pain, and and so there are lots of stuff going on there. But the point is that in our good old Anglo-Saxon background, okay, which is what I am, white male, apparently not very popular at the moment, but anyway, a white male. But the point is, our culture is that if you cut your arm, then you deal with the cut. You don't worry about how you feel about it. Okay. Yeah. And same with a sprained ankle. It hurts like hell, and you might be worried about it, and you might catastrophize about it, and you might be a depressed person and all that stuff, but you still have to fix the ankle. And back pains are no different. Now, the next question is, can you diagnose the tissue origin of pain? It's just that one part of it, remember, the anatomical origin of nociception. And the answer is yes, you can, in 80% of the time, maybe 90%. The question is, do you have to? Is it necessary? And the answer is sometimes, depending on your caseload. If you're a primary care, most of the time you don't actually have to. You might be able to, but you don't have to. Okay. And then the next thing is that what is needed to do that? Well, if you're with Dr. Aprill and you can stick a needle anywhere under guidance by a fluoroscope, and you can put anesthetic wherever you want them, well, of course you can diagnose them. But do you need to do that? Do you need to subject a patient to diagnostic injections, CT scanning, MRI scanning, just to know that the disc was painful, or the facet, or the sacroiliac joint, or the hip joint, or a buttock problem, or whatever, or a blocked artery, for example? That can also cause pains that look like back pains. So the question is, no, you don't have to. And my research has been aimed at trying to predict the invasive and expensive diagnostic procedures that can diagnose these things. Can we actually predict those, what we call reference standard diagnostic procedures in a way that is sufficiently accurate or consistent that's clinically useful? That's what I do. So I don't do the injections. That's for other people who have different skills than mine. What I do is I see if I can, in my research, can I predict those injections? Facet joint blocks, sacroiliac joint blocks, epidurals, provocation discography, MRI findings and stuff like that. Can you predict those? If you can, then you don't have to do them unless things are not going well. And that's what my research and my clinical practice and my teaching is mostly about, is that what do we now know? How good are we at identifying discogenic pain? How good are we at identifying facetogenic pain, sacroiliac joint pain, hip joint pain, et cetera, et cetera? How good are we? And the answer is actually not bad. Are we perfect? Absolutely not. All right? I'm not God. All right, and neither is Charles Aprill either, by the way. There are errors, and the science of this is about managing the errors, knowing that you might have a 90% sensitivity and 90% specificity, which means you're going to miss 10%, and you're going to get it wrong 10% of the time. All right, so that's okay, so long as you know you're doing that. All right, so we're not laying down the law. You have discogenic pain and you're going to die. We don't do that. All right, we give ourselves the information from which it helps us augment our care of that patient. And to me,
That's so awesome that you can save money and save time.
Oh,
and
huge.
it's huge. Not submit the patient to unnecessary procedures. So
Absolutely.
it's revolutionary. Yeah.
I mean, I take, for example, I had a colleague of mine who's a 30-year-old. He's 34, I think. In fact, he's one of the models in one of my courses, and I've worked with him for years, since he was a student, actually. And he was my model back in July. So I've got a big flexion, extension, and backward bending, and all my tests and all that sort of stuff, and I'm using it in my course material. And he rings me on January the 5th, 5 months after we did those videos. He says, Mark, I've had, ever since August, it's a month after I videoed him, I've had this terrible leg pain, and it's ridiculous pain, and I know what I've got, and it's not getting better, and can you look at me? So I had a look at him, and I made a diagnosis of S1 radiculopathy and radicular pain with disc herniation at L5-S1 on that side. Clinically, it's crystal clear. I mean, it's so easy, I make this a joke. This is a joke. It's so easy that even an orthopedic surgeon can do it, right? So anyway, that's a joke, by the way. It was told to me by an orthopedic surgeon, right? So it's not just me. I've just looked at the videos, the images last night, and guess what? He has an L5-S1 paracentral protrusion pressing on his S1 nerve root in the subarticular recess. So in other words, yes, we can diagnose these things. Now that's a simple one, but we can do the same with facets. Oh, well, not so much with facets. We can deal with discogenic pain, or it's just a subset of that. We can do that with sacroiliac joint. We can do it with hips, and we can do it with a number of other things like stenosis and spondylolisthesis and what have you. Now, there is one thing that I think it's really important that people understand, that diagnostics is a reasoning process. There's no test for sacroiliac joint. There's no test for discogenic pain. There are tests that we interpret. Okay? This is really important to grasp because, for example, if you had 10 tests for the sacroiliac joint and they're all positive, but so is all the tests for discogenic pain, and so are all the tests for hip joint, what are you going to believe? So positive tests by themselves mean nothing. Same with negative tests. If all the tests you do for a particular structure are negative, does that really mean you haven't got the problem? So to me, it's the contrast between the positives and the negatives, always. It's not just whether a person has a particular problem, but if they don't have it. You have to be able to do both. They do have something or they don't have something. The test is positive, the test is negative. A group of tests, how many positive tests contrasted with the negative tests actually give you the answer? It's really important. So, for example, most people listening may well know my sacroiliac joint protocol, which is you've got to have 3 or more positive tests, provocation tests that are positive, producing the pain, and they can't be centralizers, right? Okay, there's a negative and there's a positive. Just the test by themselves gives you a likelihood ratio of 4.2. But as soon as you take out those people who are centralizers, their 3 or more positive tests, likelihood ratio jumps to 7 because you've removed the false positives. See? So it's a balance, not a balance. It's not really a balance. It's a contrast. If you are looking at a picture that's all white, you've got no picture. If you've got a picture that's all black, you've got no picture. It's only black and white that gives you a picture, or add colors. See what I'm saying? So it's a contrast. Diagnosis is a skill of understanding what's positive and what is negative. Now, what I do, I have a course which is a course that's on diagnostic accuracy. It's available online. In this diagnostic accuracy course, I show you a process where you start off. The first thing you do is that you do your assessment and you get all your data and you look, are there any positive tests that are highly specific? Because we know that if you have a highly specific test that's positive, then the diagnosis is made. Take, for example, a person comes in and you've just got one piece of information. Is you lift up the leg on one side and it produces the sciatica on the other side. It's a cross straight leg raise sign, right? If that's positive, you've got a herniated disc, and the certainty of that is about 95%. So do you have to do all the other tests? The problem is that only about 12% of people with herniated discs actually have that sign positive. So you miss the other 88% of people with herniated discs because they don't have it. So by itself, it's useless. It's only useful for people when it's positive. It's useless when it's negative, okay? Similarly, if a person has a straight leg raise 45 degrees and it produces the sciatica on the same side, what do you think? Is that a herniated disc or not? Well, the answer is maybe. Is it a hamstring strain? Because the hamstring strain will do the same thing.
Could be, yeah.
No, the hamstring strain does do the same thing. And the reason why you don't take any notice of the straight leg raise test and the hamstring strain is because the patient points to the bruise on the back of their thigh. Right? Because you have other information that tells you that the straight leg raise test is not something you really worry about in a person who comes in with a hamstring strain because you already know the damn diagnosis. Okay, so it's the balance between positives and negatives. There's a reason. So if you've got a highly specific test that's positive, then the diagnosis is made. If that's not the case, and that's most of the time.
Most times, yeah.
You have to go through a process of what we call diagnosis by subtraction. Now, that's my word for a methodology that when introspecting about what it is that I do when I diagnose, I looked at myself. I had the opportunity to look at some of the smartest, cleverest diagnosticians in the world. And I've been in their clinics watching them with patients. I've seen many, many superb expert diagnosticians, and they all do it. My expert mechanic on my car does it. Diagnosis by subtraction. And what does that mean? It means, well, if you had this condition, then that would be positive, wouldn't it? It would have to be, right? And it isn't positive, so it can't be that. Take the shoulder. If I tell you that resisted abduction to max is strong and painless, resisted lateral rotation is strong and painless, resisted medial rotation is strong and painless, can you convince me that this patient could even have any rotator cuff lesion?
That would be tough.
No. So if they have shoulder pain and those tests are all negative, then you can rule out rotator cuff. Now, that doesn't mean to say you can diagnose rotator cuff lesion that way. It's just because people who have pain with that might have pain for other reasons besides the rotator cuff. But it means that you can't rule it out.
Yeah.
So diagnosis of subtraction is an absolute essential part of the diagnostic process. Okay? And so you go through a process of highly specific tests. Then there's another part of the process called pattern recognition. For example, if you do your examination, the person comes in, they've got dominant leg pain, they've got a big toe that's weak on that side, they've got straight leg raise limitation, and it only happened about 3 months ago, and it started off as back pain and then went into the leg, right? And so what's that pattern tell you? They've got a herniated disc. Everybody knows that, right? I mean, it's not rocket science. It's really simple. That's a pattern, okay? And so we do pattern recognition all the time. And in fact, we know that the average GP makes most of his diagnoses by patterns. He does it within 2 minutes. Or she, that's what happens. And because they see it all the time. Patient walks in, they've got a sweating face, and probably got COVID right now, right? It's a pattern. You see what I'm saying?
Yeah.
And so that's what they do. I mean, it's not rocket science. So you go from highly specific tests to pattern recognition to diagnosis by subtraction, and that guides your process.
Yeah. So you got that through your experience, observing over the years and trying to recognize these patterns.
You ask yourself, people keep saying, how do you do that? How do you do that? I'm going, how the hell do I do that? And then I look at somebody else and I'm saying, how did you do that? And he goes, well, it can't be this and it can't be that. And by the way, that test is positive, so it's got to be. And they all do it. Everybody does it.
Yeah.
Anybody who's any good at this does it. It's not rocket science. It's your mechanic does it. If you go in there and your car's stopped, and he goes, when did it stop? He says, I was just driving along and the car stopped. The motor stopped. He says, oh, it's electrical. Because if it was petrol not getting into your engine, it would go, not just go like that. Only electrics do that.
Yeah.
Right? That's a highly specific test.
Yeah.
Mechanics do it.
Yeah.
The plumber does it. Your plumber does it. Any diagnostician of any field does the same stuff. It's an intellectual process that only humans can do.
Yeah.
And we do it with just about everything that we're involved in technology.
It makes sense. It makes sense. And so my question is, with this diagnose, so how do you treat and manage this acute and chronic pain?
Right.
Here we go.
The first thing I want to say is that non-specific low back pain is not a diagnosis. It's a symptom. Fair. It's a description. It's a label you give a person before you know anything. If that is your end point, then you are confessing you know nothing.
Agree.
So now you go on to all the randomized controlled trials that have been done on a bunch of people with a symptom about which nobody knows anything. So is it surprising that if you take 100, 200, 300, 500, 1,000 people with non-specific low back pain, and you compare exercise with medication, manipulation with strengthening exercises, surgery with no surgery, what are the results going to be? The answer is nothing is better than anything else. And we have 25, 30, 50 years, nearly 50 years, 40 years anyway, of bitter experience of the fact that non-specific low back pain gets better or doesn't get better, irrespective of what you do, on average. Why is that? Is that because no treatment works better than doing nothing? No.
I think so.
That's the first thing. The second thing is that does back pain actually have a good prognosis? Well, originally in 1966, a paper was published by Delane et al., where they compared, this is out of the UK, the people having back pain, and they observed what happened. And they found that something like 80 or 90% of people got better, right? And that ever since then, they've said that back pain is a good prognosis. What is not well known is that that was taken from data coming from the doctors, the general practitioners, and they assumed that a person who didn't come back to them as having gotten better.
Mm-hmm.
So that means that 80 or 90% of people don't go back to their doctor when they don't get better. Now, what we now, well, they should say, I'm sorry, I haven't actually said that quite correctly, but anyway, it doesn't matter. What it means is that's rubbish science. Now, back then, it was the only science.
Yeah.
Right? And I was still a teenager back then. So bottom line here is that when you have a group of people who will not go back to the doctor because the doctor didn't offer them anything, that is not a patient getting better.
Exactly.
Okay? So the next thing is that, all right, what is the prognosis? Well, we know that something like 30 or 40% of people experiencing their first episode of back pain still have significant symptoms at 12 months. Now, is that a good prognosis?
I don't think so.
I don't think so. We also know that it's a highly recurrent disease, that it may get better, but it comes back, all right?
Yeah.
like the common cold. Right? Now, have we got a cure for the common cold? No. But we do know how to treat it symptomatically. Do we beat ourselves to death because we can't cure the common cold? No. We haven't got a cure for it yet. Have we got a cure for back pain? No. Why are we beating ourselves to death about that? At least we know the common cold is caused by at least one class of viruses. That's simple compared to back pain, because back pain can be caused by the disc, facet joint, the sacroiliac joint, a whole bunch of things. There's something like 100 different conditions that can give you the symptom of back pain. I think about 95% or even more is caused by about 11 different conditions. Okay, but there are many different possibilities. All right, so that's fine. And now if you take those, say 11 conditions, which is 95% of the problems, and then and each one of them should have a different treatment, because you wouldn't treat that the same way as you treat that. You wouldn't treat that the same way as you treat that. So they should have different treatments. And then you put them all together and you compare exercise, which is a non-specific treatment, right, to a non-specific group of people, you're going to get garbage. Garbage in, garbage out. So if you're planning an RCT right now, compare on non-specific low back pain, save your money, do something else. We know what the answer is. The answer is it's going to be no better than doing nothing. Or if it is better, it's marginally better. All right, this is not new science. Yeah. Moritz von Tilda did his PhD on this. He wrote a book in 2001. This is now 20 years ago. And the conclusion was, from all the RCTs that have been done, the evidence strongly suggests that the differences between treatments are small, if there is any. Now, that hasn't changed in 20 years, right? So why are we doing more RCTs? To find out the same damned answer. So what is left? Do we know how to treat subsets of back pain? Well, the only subsets that the researchers seem to be interested in are the ones, well, if we treat depression or fear avoidance, or we do this, all the psychosocial predictors. And you know what? That doesn't treat the pain. It treats the condition or the behavior. It doesn't treat the pain. Cognitive behavioral therapy and cognitive functional therapy, which is the latest flavor of that by O'Sullivan, all right, shows we know that you can improve people's disability or decrease their disability, but not the pain. So why do people come to see me? Well, I asked them that. I actually asked them that question. After I finished my clinical history, the first thing I asked my patient is, what do you want from me? What, I know what the person who referred you to me wants because they wrote me a letter, but I want to know what you want from me. What would help you? And 90% of my patients say, well, I'd like the pain to go away. They don't say I'd like to be less disabled or less anxious or depressed. They don't say that. Now, they may also say that, but almost all of them say, I want the pain to get less. I want to know why I'm hurting. I want to know what I can do about the hurting. Okay? And that's what I treat. The pain, not the disability. I obviously have to treat the disability because we know that getting rid of the pain doesn't get the patient back to work. We know that. So to me, as a clinician, I have to deal with all of that. But I begin with the patient. I don't treat populations. I treat individual people. Now, here's one little other thing. I know it's a little bit digressing from your original question. I haven't forgotten your question, all right? I haven't. But these are important backgrounds to an answer that may not be complete anyway. And that is, one of the most popular things going on at the moment is, well, we know what the risk factors are for back pain. If you smoke, you're more likely to get back pain. If you're overweight and don't exercise enough, it doesn't, you're more likely to get back pain. If you're depressed or unhappy, or you're unhappy in your job, and these are all predictors of a poor outcome. Yes, I mean, we know all these things. It's been a huge amount of research on that, and it's all true. It's all true. These are risk factors. And for example, we know that the sort of advice that people who become sedentary once they get back pain, they avoid being active. This is not a good predictor of a good outcome, right? Yeah. And so we advise people to be active. Yeah. Now, think about those series of things that we might do to advise a patient based upon risk factor analysis from the science. It's all evidence-based. It's all good stuff, all right? Now, a patient comes in and they hurt their back 3 days ago. I'm like, and you say, well, are you a smoker? Yeah, you've got to give up smoking. And the person will look at you as if you're crazy. All right, okay. Yeah, you have to remain active, Very important. He said, I can't walk. Sitting down hurts like shit. The only relief I get is when I lie down. You're out of your mind, Mr. Clinician. You don't treat people with pain with risk factor management. Risk factor management is for websites and posters on walls. It's not for treating patients. So to me, the epidemiological approach to treatment is not treatment. It's about managing populations. I don't treat populations. I treat you and you and you and you. You're a human being coming to me for care. All right, now, I may encourage them to give up smoking. I may encourage them to be more active in their lifestyle. I may say, go to the gym and get fit and flexible and all the rest of it. But that's not what I'm going to do to treat your pain. Right? So those are the caveats. Yeah. So what do I do? The first thing I do is I know that around 50%, and it depends where you are, if I'm in my primary care clinic, maybe 50 or 60% of people have a directional preference or centralized when I do the McKenzie assessment. Now, I know what those people have as the source of their pain. Only discs do that. So I know they have discogenic pain, but I don't need to know that. I can just treat them on the basis of that, and the prognosis for that subgroup is actually really, really good. Okay, so what do I do when a person, I can cause the pain to move to the middle, or they get worse with flexion and better with extension, or the other way around, it doesn't matter, or if they have a shift. What do I do? Well, I just do McKenzie, frankly, because it works. Okay, now the next thing is that what about the people who don't centralize? That's the other 50%, or 40%, or 60%, depending on where you are. Well, first of all, if they have a herniated disc, there's a bunch of options. First of all, you can just live with it, because we know that in 2 years, most people are going to get better, even if they're in severe pain right now. In fact, actually, the worse their sciatica is, and the more acute it is, and the more sudden the onset, the more likely that they'll be better in a year. All right. So a really bad case has a good prognosis. A person who has a slow onset of radicular pain, and they're not going to get better in 2 years. All right, so there's a whole bunch of options there for, depending on a particular pathoanatomic diagnosis, there are a number of different ways in which you can advise that person based upon their demographics, on their the way things have developed, and their imaging findings, and a whole bunch of things like that. So there's options: epidural injections, surgery, wait it out. These are people who are not centralizing mind. If they're centralizing, we know what to do. That's not a problem. People are non-centralizers. And there are things we can do with people with radicular pains. If they have spinal stenosis, well, do you give the person if you give a person who's frail, has a terminally ill cancer, spinal stenosis, do you give them massive surgery? No. Silly, stupid thing. You kill them. All right, that's not a good thing to do. If a person's 60 years of age and can only walk, 200 meters before they have to stop, all right, then yes, they might be a good surgical candidate, but maybe we should try some conservative care, aerobic training, and a few other things like that, and working on things like depression, because we know that older people get depressed more than younger people, etc. All that stuff. So there's lots of things to do, and it's all valid. It's all good stuff. Sacroiliac joints. Well, What can you do with sacroiliac joints? Well, there are some options, right? One of them is not manipulation, by the way, because everybody who has definitely got sacroiliac joint pain, not dysfunction, I don't use it with, pain coming from the internal structure of the sacroiliac joint. Every patient I know who has that, if you manipulate them, you'll either make them worse or they'll not change. People with confirmed sacroiliac joint pain do not respond to manipulation. Trust me on that. I've tried it. And I am actually not a bad manual therapist. I gave it up 25 years ago. I don't manipulate them anymore because it doesn't work. Now, the only people it works on are the people who are positive to all those unreliable tests. And those are the people who don't even have sacroiliac joint pain. They have dysfunction, which is different. And that's dysfunction based upon unreliable tests and invalid tests. So why would you even give them that label if it's based upon an unreliable set of tests? So I'm only interested in sacroiliac joint pain, not dysfunction. Dysfunction is a word that should get out of there. It's gone. It shouldn't be even mentioned in the same breath as sacroiliac joint. That's the first thing. All right. So, by the way, there are no randomized controlled trials on people with confirmed sacroiliac joint pain comparing one treatment to another. Zero.
Oh, wow.
We have all these randomized controlled trials on non-specific low back pain, which has some sacroiliac joints, some facet joints, some discogenic pains, some stenoses, some hip problems, some buttock pain problems. They're all in there, and they all need different treatment. That's why you get zero result from randomized controls on non-specific low back pain. So sacroiliac joint pain, there is zero randomized control trials on people with confirmed, I think there might be one or two on steroid injections. That's it. So there's no studies on manipulation, on exercise, on natural history, nothing. And same goes for facet joint pain. There are zero randomized control trials comparing something like radio frequency denervation, that's neurotomy, with conservative care, for example. None. Zero on facet joint. We don't know what conservative care for facet joints should look like. We have no idea. None.
That's
now,
crazy.
What do I do? It's not, well, it is crazy, but that's because all the money is going into these randomized controlled trials on non-specific low back pain. Spend the money where it should be spent, on stuff we know about, not on stuff that we admit we know nothing. Makes no sense to me.
Yeah. Hopefully our listeners are going to think about that, because it's something that sometimes we don't stop to think about. That's crazy.
I discovered this in 1996. Do you know why? How it happened?
Yeah.
At that time, I was still part of the McKenzie Institute, and although I had nothing personally to do with the study by Cherkin et al. In Washington State, they did this really, really good study with a bunch of good therapists who were being trained by McKenzie faculty in the McKenzie approach, comparing it to chiropractic and a $1 educational booklet. They did. Dan Cherkin did the study. He was the statistician and the lead author, comparing McKenzie, chiropractic, and a $1 educational booklet. And in essence, the McKenzie was slightly superior in one or two things, but in essence, there was no difference. And the whole McKenzie world, including me, said, whoa, that can't be bloody right. That can't be.
Crazy.
All these patients coming in and we're fixing them. Where the hell is the evidence of that? Now, that same year, I was at a conference in Lillehammer in Norway, and I had a few beers with Bart Koos. Now, Bart Koos is an epidemiologist from the Netherlands. He's done a lot of research on back pain and other things like that. He's not a clinician. He's an epidemiologist and a statistician. He's a good bloke, nice fellow. And we were sitting down getting drunk, having a few beers, and I said, "Rightio, Bart, here's a conundrum for you. We have this really, really well-conducted study that shows that what I've been doing for the last 20 years is useless. No better than a $1 booklet. He says, those are the facts. I said, it's not the facts. That's the statistics. You're the statistician. It's your job to tell me, the clinician, why it is or when it is I should be using this versus that. And you haven't done that. You've just put all these people together as though they had all the same condition. The randomized controlled trial model is based upon comparing one molecule versus another non-molecule, nothing in other words, on a specific disease. How do you apply that to back pain? That's what randomized control, it's a pharmaceutical model for a specific disease and using a particular molecule or not. Yeah? Or that molecule versus that molecule in a patient for thyroid disease or Alzheimer's or something, I don't know, whatever. So, but specific pathoanatomic diseases, molecule versus no molecule or molecule versus a different molecule. You have back pain, which is not a single disease, and you're comparing a treatment like exercise, which treats many things. How is that model even valid? It's not even valid in that circumstance. And yet it's done everywhere as the gold standard from which all the systematic reviews are modeled and all the guidelines are based. Makes no sense. I knew that in 1996. This is not new. It's 25 years ago.
And why? Why hasn't changed?
You asking me? I'm a clinician. I'm not a politician. I'm not even. I've never been a full-time academic. I don't teach in schools. I teach on courses. That's it.
Yeah.
I'm sorry, I can't answer those questions. I don't know.
So let me go ahead and ask about your course. Let me get that. So what kind of course do you teach and where you teach? I know you travel all over the world teaching. So just let's briefly talk about that.
I've been teaching in the old model for a long, long time, where you go to a place and you have a bunch of people from anywhere from 10 to 100 people, and you teach them techniques, or you do PowerPoint presentations to them and see a few patients. And one of the things that I always do in my courses is that I always treat patients, see patients, diagnose patients, treat them on the course. To me, that's where the rubber hits the road. You can talk about treatment all you like, but can you perform in public? And Mackenzie could do it. Jeffrey Maitland could do it. Mulligan can do it. Very few others can. All right? Perform in public with patients they've never seen before. And I learned that from Mackenzie and Mulligan. And Jeff Maitland, I did courses with Jeff as well. He was a great guy, so that's been the basis of how I've taught since I was in my late 20s. What I realized, about 7 years ago, I got an email from a guy who did a course with me in Los Angeles. And he says, I did a course with you in the year 2000, and you said this. And I'm going, he said, and he asked me, do you still believe this? And I'm going, I can't even remember what it was, it doesn't matter. I said, I would never have said that. I've never believed that. And I'm not senile. I don't have Alzheimer's. I have a very good memory. I would never have said that. And he says, you did say it. And I'm going, holy shit. So then I started listening to I had the one or two recordings that I had. I think in 2007, I did a presentation at a conference in Odense in Denmark to a big conference there, a huge conference. And I listened to my saying, you know what? It's really interesting when you listen to yourself. For example, you miss out words like not. But what happens is that your audience normally actually edits as they listen. So when you say da 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 is such and such, but you miss out the word not, that means you said the exactly opposite of actually what you mean. But most of the time, your audience actually knows that. And so they insert the not themselves. But this particular person did not. So I thought, okay, how can, I mean, it's a pretty rare event, but it tells you something about the live presentation, about how it's full of errors. And you listen to yourself speak, it's full of, the only person I have ever listened to who is not full of errors when they speak is Nick Bogduck. He never is. He's got a photographic memory. He's perfect memory. Brilliant, absolutely brilliant guy. But I'm not a Nick Bogduck by any means. Now, the reality here is that when you speak, it's full of errors. So I thought, okay. And here's the other thing. We've always known in the teaching that when you teach to a large group for 4 days, within a month, those people will remember maybe 10, 15% of what you said. We know this. And so we always, in the McKenzie Institute, when I was teaching McKenzie, we always knew that about 4% of people will actually get it and run with it. 4%. It's not because the technique is no good. It's just because of the way in which we do it. So there's a problem with the education. So what I did is that in 2015, Angela Cadogan and I started it, but I was asked to do a course on acute back pain. And I said, I'm going to put all my lectures up online. Instead of going to a course and have a whole lot of PowerPoints, and no PowerPoints. That's all. You do that online. And the reason is because now I do my PowerPoint online, I'm actually talking to the PowerPoint. It's a video of a lecture that I'm giving to my screen here. All right. And it's perfect because I won't allow it to be a video until it is perfect. So there are no errors. And even then, I still pick up errors occasionally. Even then, right? So all my lectures now are online. All of them. Now, so you do that online. So if you want to do a sacroiliac joint course, I got one for that. If you want to do ridiculous syndrome, I got an online course for that. You want to do diagnostic accuracy, I got a course for that. You want to do basic treatment of low back pain, if you just got out of school and you want to know what to do with your next back pain patient, I got a course for that. You want to learn, the one that I'm just about to complete now is on the advanced assessment, right? When that's, you basically got a bit of experience, you've seen a whole bunch of patients, you want to know how to expand or improve on your basic assessment, and you want to make an advanced assessment. I'm just about to complete the course on that. You want to do a course on discogenic pain, mechanical discogenic pain versus non-mechanical discogenic pain, I've got a course on that. It's all online, and I use video on patients. So normally in a course, when I go to a place to teach, I see patients and you see it live. Well, you can only see what you get on a course, right? You see this patient or that patient. Yeah. Whereas all the patients that I've videoed over the years, and it's many, many years I've been videoing patients ever since the last, nearly 15 years now. I've been videoing a lot of patients, and now I video all of my patients. And I have all these examples of this and that and the other thing. And I use video. And I obviously edit it because there's a lot of rubbish in there that needs to come out, and people swearing and stuff like that. But usual stuff. But it's a mixture of video and PowerPoints online, and I've trimmed it down just to give you the essence, and the stuff you don't need is gone. All that stuff. It's all gone. You don't need the rubbish, and we get rid of the rubbish. So it's down to what do you need to be. If you want to be a back pain clinician, then you start here when you're just fresh out of school or you're still a student. That's called Back Pain 101. That's been online now since October. Then if you want to go further, there's Back Pain 201 Advanced Assessment. That's the one it'll go live in about a month. Then you have my courses, which have been online now since 2016. I'm going to be breaking that big course, it's a huge course, breaking it up into sacroiliac joint pain, radicular syndromes, mechanical discogenic pain, non-mechanical anterior column pain, the buttock and hip masqueraders, claudication, what causes that, and stenosis versus peripheral vascular disease and stuff like that. So we've got courses, those are going to be level 3 courses. And that's doctoral, clinical doctorate level stuff. Level 3 is clinical doctorate. Advanced stuff is like advanced practitioner stuff. And then there's the basics. You got basic, 101, 201, and the 3-level courses. And that's what I teach now. Plus there's my diagnostic accuracy course, which is, it's using lumbar spine data, but it's actually applicable to whatever science, what area of the body you're in. So that's what's online now.
Nice. So you got to adapt to this pandemic world that we are living. So everything online makes it easier.
We didn't have to adapt because we're already doing it.
Oh, cool.
No, we've been doing it before COVID.
Good.
So that's that. I mean, last year I got the basic 101 course completed and online. I've got one course there of a series of 3 cases, 1 sacroiliac joint, 1 facet joint, and 1 anterior derangement, which is mechanical discogenic pain. That 3 case studies up as well. So that's a whole thing with the video of all the patient, all the case notes, all the images, everything. And
awesome.
And a follow-up, a 12-month follow-up as well.
That's very nice. So I'm going to make sure to put that on the show notes so people can take a look.
Well, it's all there, and you know, it's pretty simple. Anyway, it's southern.musculoskeletal.courses. That's it. Southern stop musculoskeletal stop courses. Okay. That's the address, and you just do info at musculoskeletal.courses, and I think that's what you use.
Okay, sounds good. So
anyway, you can just log onto that and have a look. It's all there.
Good stuff. So let's just move to our final questions that I ask every guest. So what is your favorite resource of information? Any books, specific papers that you would like to share?
My favorite sources of information. I spend an hour every day on Twitter, and Twitter is a lot of people singing to their own choir. We know that, and I sing to my own choir, of course. But there are a few people on there I particularly like, anything from Chad Cook. David Poulter is also a very interesting person to follow. Chad Cook is outstanding. I like Sorensen. He does a lot of blogs and stuff like that, and he does podcasts and what have you. He's got physio tutors. They're good. So there's a lot of online stuff that's really, really good. My source of most of my information in terms of my papers is that I use PubMed all the time. For a basic search, it doesn't get all the literature because it's only the stuff that goes into Medline and stuff like that. But by and large, PubMed covers and it's free. It's right there. You get the abstracts and you can do searches. Learn how to use your PubMed. To me, that would be one of the most important sources of information. Of course, you'll get lots of rubbish. There's an awful lot of rubbish on that as well. ResearchGate, that's another good online resource. There are good people on ResearchGate. And I am a member of LinkedIn, but I don't see that as quite as useful. That's fine. But Twitter I find useful. And I spend 1 hour a day on social media. That's enough for any person. And I don't go into Instagram. I have a Facebook page. Southern Musculoskeletal Seminars has good Facebook pages. I have my own personal Facebook page as well. I'm not active really on that so much. It's okay. It's good to put stuff off it occasionally. But to me, I'd much rather people get engaged in the formal process. The social media is great for a community, if you like, of people thinking and talking and discussing. But formal research, use your library, use your PubMed. You can use, I shouldn't even say the SkyHub is a good source, but that's illegal, so we don't talk about that. And so, but the reality is that get your papers and get your abstracts. If you want a paper and you can't find it, then go on Twitter and ask people, and they'll give it to you.
Yeah.
So that's the sort of thing.
That's good advice. And what would be the best advice you can give to a clinician that is starting their careers?
Generally speaking,
yes.
Or specifically for back pain?
Whatever you prefer.
It really matters, that first year or two, really matters where you go to work for, where you go to work. You've got to get a job. You've got to earn a living. So you've got to go somewhere. But don't be defined by what economic circumstances force you into being. All right, I think it's really important to get that. I was lucky. My second, pure luck. I had Ian Broadfoot even before I qualified, just filling my mind with good stuff. Then I went straight into private practice. I had the opportunity to put some of that into practice and see where it worked or not. Then I had Mulligan and McKenzie and other people like that. I mean, no, that's unique. It's like you just don't get that very often. So most of the people listening will finish their physiotherapy training or maybe medical school for that matter, and they get the first job they can get because they want a job. They need a job, right? And that's fine. But what you're looking for is a clinician to work with, whether they're in a public system or a private practice, doesn't matter. But work somewhere where the clinician actually is practicing something that has some, for example, I wouldn't matter if you were a physiotherapist and went and worked for a person who's a pure Maitland person, or a pure McKenzie or a pure Mulligan. That's a great start, okay? Because you're going to get so long as they teach you the basic skills on how to assess and examine and actually put some of your knowledge into practice, then you've got a baseline. Get a baseline. Start seeing patients, have a method. All right, have a method, get a method. Don't necessarily be wedded to that method forever. All right? Don't become the eclectic, empty-minded person who goes to the course and that's what they do. They go to the next course, and then that's what they do. Go to another course, and that's what they do. That's, to me, is mindless. Have method. Try and develop a system that fits your own personality. Because we're all different as clinicians. Patients are different, but we're different. What suits me in the way to practice won't necessarily suit you. And so you've got to find something that keeps you passionate about being a physiotherapist. And that's really important.
Yeah,
and you need a system for that.
Yeah.
And if you want to learn, obviously, I mean, I'm just advertising now, but if you want to learn how to be a decent back pain clinician, do my courses. But if you want to be a good shoulder clinician, do Angela Kanokan's courses. And there's also there are many other good courses too. But I mean, but really, that's the sort of thing. If you want to learn the McKenzie system, go to the McKenzie courses.
Yeah.
Now you'll get what I think is important from the McKenzie thing from my course. But actually, if you want to learn the McKenzie system, there's only one place to go. If you want to learn the Mulligan system, go and do the Mulligan courses. That's fine.
Yeah.
It makes no difference to me. What's important is that you get you need handling skills, you need assessment skills, you need to understand pain, the pain experience. You need to have some cognitive behavioral therapy skill, but you don't treat back pain by that. That's not for treating back pain. That's for treating human beings. And it's an augmentation of a system. It's not the system.
Yeah.
Right?
Yeah.
It's really important.
No. Absolutely. And my final question, what personal qualities and abilities do you think are important to become a successful physical therapist?
Well, I've already said the first thing is you have a system that you're passionate about and that you want to help people recover from pain and get back into their lives. And you use that system. You have to be passionate about it. Passion is key. All right. You can be scientific and logical and all the rest of it. And that is a great way to develop your context and your knowledge and all the rest of it, but it won't keep you in the profession. Passion will.
Yeah, I agree. So, Mark, thank you so much for all your time and for sharing all your knowledge, all these years of experience. And I really appreciate your time, and it's an honor for me to have you here. And I'm sure my listeners are going to really love our episode. And for people that want to know more about you or even contact you, do you have any contact info that they can reach out?
Sure. Probably on a daily basis, they can just follow me on Twitter. That's easy. They can obviously look at my Facebook page, which is easy to find as well. And although I don't really update it, but there's actually a lot of free stuff on there. I've got a lot of quite a lot of free resources there, so you can actually look at my Facebook page as well, and I can give you that information when we go offline, and you can put it associated with that. And of course, the Southern Musculoskeletal seminars, the course material, and Rachel, who is our administrator, she knows well. She lives not far from here, so she's we know each other well, and we interact on a regular basis, and so contact Southern Musculoskeletal seminars or Key Clinical Skills. That's another good group to be. They've got some good courses.
Awesome. Okay, thank you so much, Mark. It was a pleasure to have you here, and I hope you had a good rest of your day there.
And get vaccinated. Every one of you, get vaccinated. If you don't get vaccinated, I ain't going to come to Brazil. I'm not going to come to the USA until everybody's vaccinated.
Yeah.
All right. I'm 71 years of age. I can't go anywhere until anybody's vaccinated.
So yeah,
right
please. Yeah.
I'm first on the list.
Okay, Mark. Thank you so much.
A pleasure.
Bye-bye.
Take care. Thanks for inviting me. I appreciate that.